All right.
Hi, everybody. Welcome to the Digital Culture Speaker Series. We have Lauren Wilcox today, who comes to us from Google Health. I'll give a brief introduction to Lauren. I've known Lauren personally for a long time, and it's an honor to host her here as a speaker. So Lauren Wilcox, PhD, is a research lead in the Google WellBeing Lab and an associate professor at Georgia Tech, where she directs the Health Experience and Applications Lab. And previously at Google Health, Dr. Wilcox led initiatives to align AI advancements in healthcare with the needs of clinicians, patients, and their family members. She was recognized by the NSF through a career award and by the Agency for Healthcare Research and Quality through a dissertation award. She's authored several well-recognized papers, heavily cited, and she is an inaugural member of the ACM Future of Computing Academy and frequently serves on the program committees and organizing committees for many premier conferences of the field. And she received her PhD from Columbia University in 2013. And it's a pleasure now again to pass the mic on to Dr. Wilcox. Thank you so much, Lauren. Go ahead.
Thanks for that introduction. So I'm really happy to be with you today. You gave a great introduction. Thank you so much. I'm kind of inhabiting two worlds right now. So at the WellBeing Lab, we define well-being principles and guidelines and operationalize these through toolkits to bring well-being into the design of technology across Google, but also providing guidelines and toolkits for the public. So we, are really focused on bringing well-being as a really core objective into all of our computing systems. And in parallel, we're also applying design and user research to shape emerging digital health products. At Georgia Tech, my group studies the perspectives of families, individuals, and clinical caregivers to shape personal health applications. And we focus a lot on people's environments and experiences to bring them to bear on technology design. And we're motivated in doing this by the fact that, when we interact with computing systems in health and well-being contexts, we're interfacing, not just with an electronic health record system or a mobile application, but with sociotechnical systems. And so I know this group is probably very familiar with what those are, but just to summarize, the term sociotechnical indicates that inextricable link between the social and the technical components of a system. And so we know technology shapes culture, it shapes our workflows, and ultimately, collectively, the society in which that technology is embedded. But at the same time, culture, work practices, and societal norms, these things shape technology design in the way that we build and test technology. So to consider a system to be socio-technical is to acknowledge that that really important interplay, right? That the way that it functions or performs overall emerges from that interplay of its envisioned design or its envisioned purpose and its actual use. And so it's really important to understand these sociotechnical systems because we can't really study, computing systems in isolation and really understand their impacts. And as well, we can't really study people's practices independent of the influence of computing systems. And so I want to kind of walk through a case of how important this interplay is. So Dr. Bob Wachter documented and published a case from UCSF Benioff Medical Center. The case was published in Medium and Wired, and also in his book, The Digital Doctor. And it walks through a tragic medication error that almost ended a 16-year-old patient's life. So though it was published in 2015, this case study actually documents issues that researchers are still grappling with today. And it's a really compelling example of the need to design and build for that intertwined social and technical phenomena. So this article introduces us to Pablo Garcia. He was being treated at UCSF and he suffered from a rare genetic disease. And this compromised his immune system and it required that he go to the hospital for colonoscopies. So he had frequent infections and bowel problems requiring these colonoscopies. And that day he was in the hospital for a routine procedure. Well, Walker explains that a resident physician needed to place about 15 drug orders for Pablo. He was taking many medications at home because of his rare disease, but also needed to prepare for this colonoscopy procedure. Well, one of these medications was for an antibiotic called Septra. The generic name for its key ingredient is shown here in the UI, trimethoprim. So to order a medication, physicians use an order entry UI that looks like this. This is not a screenshot, of course, this is a faithful representation of the UI. The thing to note here is that for Pablo, the UI defaulted to a weight-based dosing policy because though he was 16, he was only, he was only about 85 pounds. And so for kids under 88 pounds or 40 kilograms, doctors order medication based on the milligrams needed per kilogram of body weight. So rather than ordering, if you want a single pill that's 200 milligrams, you wouldn't order, 200 milligrams. You would order it as, if the kid is 40 kilograms, you would order it as 5 milligrams times the 40 kilograms of the child's body weight. So of course, this is done to be safer about medication doses, for kids that are under a certain weight. So the UI defaulted to this order entry in milligrams per kilogram. And when the resident typed Septra, which was the antibiotic they wanted, into the order entry module, they had a couple different options. They could select 2.5 or 5 milligrams per kilogram, and they correctly chose 5. And because Pablo weighed about 38.5 kilograms, the system then multiplied this weight by 5 milligrams, determined that the dose should be 193. Well, Pablo, this was a continuation of medication Pablo was taking at home. They really just wanted 160 milligram pill. So the resident accepts the closest fillable dose, which is 160, and thought they were finished. But the system detected that the dose that was actually calculated, the 193 milligrams, was too far off from the 160 milligrams that they wanted. And the pharmacist couldn't fill it because the hospital had this policy that, it's greater than 5% of a difference. So we can't allow the pharmacist to fill this order. Okay. So, the pharmacist texts the resident, asks them reorder the medication and the dose needed, 160 milligrams. And here's where things break down. So the article goes on to explain that some time had passed, and when the resident revisited the order entry, they type 160, right? They see the text, they have to order 160 milligrams. They type 160 here, and I've highlighted the form fill-in box in orange, and they resubmitted the order. And so, we can see how problematic this is. The resident believed that they had just ordered, the one tablet that they wanted all along, but they were in the wrong mode. So they actually ordered 160 milligrams per, roughly 38.5 kilograms of Pablo's body weight. So, alerts were generated since this was an overdose, but the resident dismissed the alert, figuring it was clinically insignificant, and an order for 38.5 antibiotic pills went to the pharmacy, signed, and then validated by a licensed physician. Well, that, shouldn't have been too much of a problem to catch, right? Because the pharmacist would have, at the pharmacy would have to accept this order. So the clinical pharmacist receives the order, but they didn't realize it was in the wrong mode either. And the article explains that they were, kind of balancing phone calls, visits for pickup. So anything narcotic has to be picked up in person by the pharmacy. So that can be a bit of a distraction, and other interruptions. So they see 160 milligrams, they accept the order, and they dismiss their own alert screen. Well, there might have still been a chance to catch this if a technician were on staff pulling the pills, right? To actually fill the prescription. But in this case, the approved order was sent electronically to be processed by a pharmacy robot. And so this robot is programmed to do the work basically of a technician plus. So they pull medications off shelves to put these into packages and bind these packages together, send them to locked cabinets on the right patient floor. And pharmacists would normally check the human technician's work before a medication leaves the pharmacy. That would have been yet another chance to spot these 38.5 pills. But because the robot pharmacist was filling the order, the protocol was different. There was a lot of trust in this robot because it executed the tasks that it needed to do fairly perfectly. So because the robot pharmacist was actually filling this order, the technicians that are there just sort it to make sure it gets to the right location, put it in a bin for transport, and that's it. And so, now at this point in the workflow, we're at the phase where the focus of medication safety efforts kind of shifts, right? From making sure that the order is correct to making sure that the administered dose matches the prescribed dose. So a nurse is the one who, takes these medications from the trays, verifies the prescription, and administers the drugs. The nurse thought that this dose was odd, but she scanned the medication order to make sure it was correct, and she trusted what the system read. So she gave Pablo, the 38.5 pills. And, this case shows us that many of the new holes in sociotechnical systems, weren't just caused by an algorithm doing something wrong per se, right? But they actually involve this confluence of factors. So luckily Pablo lived, but he went through something really scary. His family went through something really scary. He had a grand mal seizure. He spent, several days in the hospital. His mother started, planning for the worst. And, the medical system didn't quite know what to do. This was the first overdose of this kind. So the story really highlights, these complex challenges that arise when humans in these novel computing systems work cooperatively. The nurse saw a large number of pills, but, as the article explains, she rationalized this kind of weird order, right? This is a rare disease patient. Maybe he's in a clinical trial, in which case sometimes these large doses of medications are okay. Maybe the formula is diluted, and that's why there are so many pills, because the concentration is much lower in each one. The article doesn't mention what processes were in place to stop the line at any point, for someone to say, this doesn't seem right. So, but based on what I can gather from the story, it sounds like changes to defaults would have taken significant workarounds. For a nurse to stop the line, they would require risk-taking, social risk-taking, because you'd be questioning the physician's order, she'd be questioning the clinical pharmacist. And in this case, the nurse was a floater, so she generally didn't work on this floor. She generally worked in the pediatric ICU. So it would have been even harder to challenge the decisions of these other clinicians in the medical hierarchy. She would have had to do repair work to try to figure out if she did decide, no, this isn't right. She would have had to do some repair work to figure out, what could have happened? Who should I ask? And then how do I contact them? How do I try to fix whatever this might be? And then finally, with the heavy task loads, she might be delaying the medication for the next patient if she were to flag this. So, she's on a schedule, patients have scheduled medications. Pablo had a scheduled colonoscopy. So, part of this, and I don't know, I'm not, saying anything about the particular organizational culture, but at this particular hospital, but, we know that the organizational culture needs to be able to support, right, these kinds of stop the line actions and create a psychologically safe environment for doing that. And we have lots of other factors too, right? The UI design not quite fitting the needs of this workflow, the alarm fatigue. The article explains that about half of the medication orders were generating alerts at the time. And so most of these were clinically insignificant, and that increases the chances that they'll just be blown off. And so these are just some of the factors that we need to think about as we bring sophisticated computing technology to health and well-being applications. We know that novel computing systems often have issues moving out of an R&D environment and into real world environments like clinics, or even people's homes. In healthcare settings, we know that clinicians might not even find new solutions useful. Logistical hurdles that weren't planned for can slow deployment. in many cases because they just weren't considered, early on as part of the technology development process. What it would actually mean to integrate, into an environment. And there can be challenges when it comes to doing that actual integration of systems and workflows, because, it's often hard to know what is the work that clinicians need to do to make the system work. And, that can mean that the work, even though the promise of certain AI systems is to streamline work, often some of these systems can make workload for certain clinicians worse, not better. And in worst cases, these systems in the wild don't actually improve clinical accuracy. So, so one way to get ahead of problems, right? I'm kind of painting a bleak picture here, and I don't mean to be totally bleak here. There are ways of combining human-centered computing research with the types of technology development that are ongoing to help, maximize chances of success. And one way to get ahead of problems is, of course, to involve stakeholders in the process, in the entire process of creating, machine learning or AI-based systems, from problem selection, to multi-stage evaluations, to how we deploy technology, and then onward into post-deployment. So I'm going to talk about some projects that use participatory approaches at different stages of this pipeline. So I'll just call this a pipeline for the purposes of this talk, and we'll kind of visit some of these different stages and look at how we can think about participation from people for whom this technology is being built. So let's see. So starting with mobile health technology for adolescents. Here, we're designing specifically for adolescents with chronic conditions. Interestingly, and this was new to me when I started doing this research, almost 1 in 3 adolescents in the US has a chronic condition, and 13% of adolescents have 2 or more conditions. Fortunately, not all of these chronic conditions cause severe disruption to daily life or limit activity, but when we look across different conditions that do limit activity in teens, we can see overall that these are increasing over time. So this is data shown from 2 years that the same survey was conducted, so they're kind of reliably comparable. And so we can see this number has increased in the last 12 to 13 years. And I show these slides to show that teens are engaging with health information and health management differently today. So in the past, supporting teen health meant teaching teens to avoid things. Teaching, I've certainly, my experience as a teen with health was being taught to avoid smoking, to avoid drinking or sexual behavior that was risky, right? And instead cultivating healthy habits. But teens are having more difficulties now with chronic illnesses, and in many cases will have to navigate the healthcare system. So this is not a skill that we thought that teens need to master. But in fact, as we see chronic conditions on the rise, it's a key consideration when we're thinking about what interventions mean and what the computing agenda, right, for supporting health and well-being really means. So this is a paradigm shift in kind of how we think about needs and how we have to think about management of health in a little bit more high stakes ways, and not just prevention, right? Prevention is important, but it's not enough anymore. So we conducted studies at Children's Healthcare of Atlanta, spanning multiple clinics and settings. We worked in the Atlanta, more urban location. We worked in suburban sites, and included 3 stakeholder groups. So we worked with cancer patients, patients with blood disorders, and lupus patients. And we had a 5-year partnership with my lab with CHOA, where we were able to really have kind of the honor and privilege of getting to know these patient families. So first, really to understand the current state of teenage patient engagement and where teenage patients were kind of having needs that weren't being met, we conducted in-depth interviews. We did a bunch of field work. We observed consultations to learn more about needs and challenges. And we did this initially with oncology patients and patients with blood disorders. We conducted 38 interviews. We observed 14 oncology encounters initially, and then just collected a really rich set of qualitative data where we had segmented transcripts from interviews, observation notes, and this really helped us understand kind of what are the problems that we could focus on that technology could solve. What kind of data would we need to collect, and what outcomes are we going for? And so one of the things we found was that both teens and parents have unmet needs related to information access and communication, and they often mention diagnostic data. And this was pretty interesting because we figured, well, you've been diagnosed, so wouldn't you kind of have a better understanding of the status of your diagnosis, like what your diagnosis is? That's kind of an assumption that would be easy to make. Like, if you've got a condition, you know what it is, and you know what data led to the conclusion of that diagnosis. We actually found that all parents wanted more electronic access to data, or better ways of managing access to data that they had access to, and teens wanted access to more information too. So some mentioned that their doctors perceived them as being unable to understand detailed explanations, but they wanted more than what they were getting. So they were often perceived to be disengaged and not really participating. But what we heard from them were things like, sometimes I tell my mom questions to ask them so that I don't have to ask them. They don't want to explain everything to me because they think I won't get it. But if my mom asks a question, they'll go into full detail. So this was really telling for us that there wasn't a perception that it was okay to ask these questions. But imagine that you're a teenage patient who doesn't have that relationship with your parent where you can tell them what to ask the doctor, or you don't even have a conversation about, hey, we're going to the clinic today. How do we want to plan this, right? So, both teens and parents had these unmet needs related to information. And, patients with these conditions were getting routine MRI and CT scans. And they really appreciated when they could see the reports and the images. We learned things like, the scans make me feel a little bit like I'm in there. I can see what's wrong with me, so they don't have to tell me in some weird way. Or teen number 4 in our study who said, I want the MRI results to see what they see so I can better understand it. So, we also talked to clinicians. These clinicians were supportive of new ways of providing these data and helped us understand some of the constraints and considerations, like timing, of the release of this information matters, and a little bit more of nuances of the timing, right, that we have to think about, and the form of delivery. So, we narrowed in on the problem of supporting patient-friendly radiology reports because this was the most salient clinical component of the imaging study. Radiologists actually, the referring physician, the oncologist in many cases for these patients, the oncologist would refer the patient and the radiology exam to a radiologist who would then do the study and write the report. And so these reports that was where the good information was about status and progress. And so now it was time to kind of find out how design could work best in addressing families' needs. So we conducted a multi-phase study to inform the design of tools that could help families kind of navigate these reports better. And so we kind of had outcomes that we now identified, right? Like, we knew that patients and family members really valued this data, but that it wasn't interpretable in its current form. They kind of had a hard time navigating these reports. And so now we had the outcome of, how do we create patient-friendly and family-friendly interactive reports that are more understandable. And then that helped us then, of course, move into these other phases of the pipeline of, like, how would we develop algorithms to support that? How do we evaluate our thinking as we go about this process? So we conducted studies, and I won't have time to go through the whole process, but we started by analyzing online health forum data to examine, what are the questions that patients are asking, specifically patients who are interacting with these radiology reports. What kinds of questions do they ask? how are answers given? What are the stylistic considerations and how these things are explained? We also, in parallel, ran language modeling and text analytics on 200,000 radiology reports and distilled the most common phrases to go over with radiologists as a starting point for how to better communicate the ideas in the report. And so we had 7 radiologists reviewing these data with us and results of our analyses. And they helped us distill, like, what are the functions that radiologists are really trying to serve? What are the topics and concepts that they're making sure to address? And we learned that certain phrases were commonly used across radiologists to refer to anatomy, to sort of localize the observations they were making. They use certain phrasing to describe common attributes like size or position of a nodule. And others indicated that there was presence or absence. So presence versus absence of evidence was another concept. So, we paid attention to these concepts and we were able to distill 13 of them and identified action language, like here's recommended follow-up or a general suggestion, versus descriptions of observations. And then we selected a subset of concepts that we could support through design that we determined with radiologists to be, kind of fair game for navigation and interaction design assistance. So, from those first 2 studies, we generated concept ideas and we developed a functional probe. And so, we still kind of weren't satisfied that we had enough information. Like, despite all the information we had, we still were like, okay, but gosh, radiology reports, like, we don't, the computer scientist in me, immediately went to like, oh, we'll take a technical radiologist report and we'll do some analytics and text processing, and we'll spit out a lay-friendly report. Done, right? And that is a problem, computing can solve. So let's do that, right? That's kind of like the first inclination. Well, that was misguided because, again, when we start to engage and really see how these processes work, we learned that there's heavy use of uncertainty in report language. And that's resolved through communication. And that communication is really important. So we don't just want to have kind of one translation. There's really not one translation that exists. What we want is to foster a process, right, of collective understanding from the family, the patient, and their care team, right? This cultivation of knowledge together of what do we think this means? And that, so it's not just here's your output, right? It's instead, how do we create a tool to navigate, explore together, share knowledge, resolve ambiguity, think about what this could mean and what some interpretations are, and really resolve some of this uncertainty through discussion that strengthens in the relationship. So basically, we developed a probe where, this was functional. The goal was to see how people appropriated. It was a tablet-based interactive radiology report software. And we picked this kind of technology probe approach. So this is kind of building on Bill Gaver's cultural probes. This is, probably the most common version of this that people have heard of as Hillary Hutchinson's tech probes, where they're functional. It's not just a demo. It can be a prototype, but it's not necessarily a prototype. It's functional software. It really has kind of limited purpose, right? It kind of does one thing. And the goal is to kind of field test it, right? And to see how people appropriate that. This is actually a great approach in healthcare and management contexts because, for medical stuff, it's such a complex field and such a, the complexity of the management process. It's such that like good design work is difficult to achieve because there are so many things that aren't observable until we put a stimulus into the environment, right? And then see the response. So that, for our purposes tends to work really well because we really need to get at that kind of dynamic phenomena of like the healthcare system and how some of these conversations unfold, how some of this care work unfolds. We really kind of need that stimulus there so people can use it in context. Anyway, so this is an example of some radiology report data. So when patients and families get these, they're formatted, it's much more polished, but just to give you an example of what some of the data look like. Our first goal was to structure and organize the report content to simplify navigation. So like, what are the key topics that we'll need to kind of organize content around? And then kind of just a very preliminary information architecture so that we can, for example, have a summary tab that's easy to navigate to that gives the status right away, right at the top, kind of the takeaway of the report, and then action items that might follow. We wanted to also identify and restructure the subsections so that, for example, once I know, okay, here's basically the summary status of this report, and then whether or not I need to actually do anything about it, now I can dig into like, what were the specific impressions? And so we structured some of these subsections just to help kind of with the journey, right, that most people are taking as they explore these reports. We also wanted to, clarify medical jargon. This was a big one. So we were able to identify medical phrases and entities that we could then link to patient-friendly explanatory content. So if I see, small right upper lobe nodule, where's the upper lobe, right upper lobe? I don't know what this means, potentially as a patient. So obviously, patients have varying degrees of knowledge, but we wanted to make available, right, if needed, this explanatory content that could really help take something mysterious and bring it back to something relatable. Oh, okay, it's in my right lung. Now I've localized exactly where they're looking. And for things that are described, like 5 millimeter soft tissue nodule, well, again, it's kind of helpful to bring in something familiar so that if I'm trying to picture what that means, reference measures can be helpful. Like, okay, it's a little less mysterious if I know where it is, I've localized it, and I know roughly how big it is, and it relates to something familiar. So there's of course a lot more work to do. And again, this was we weren't focused on visual design as much as we could have been here, but we wanted to understand more of the meaningfulness of the information and how people would appropriate an interactive experience like this. So, one final, I guess I have a couple more things to point out. So along the lines of like these lay-friendly explanations, we also were able to pick up things like otherwise unremarkable, which would be very, very kind of clinical language, and bring in some similar expressions like otherwise normal. Okay, so, the things have been called out that I need to know on top, and the impressions, and then otherwise, the report is normal, the exam is normal. So, of course, this isn't just about disseminating information, but gathering information from the patient about what they want to note and what questions they might have. So we also included a section for that. And then we studied use of the probe in the clinic to identify insights that emerged from its use and come up with subsequent designs. We iterated on the design so that the visual design has come farther, which is nice to see. And for this study of the probe, we demonstrated the features. We kind of did this guided tutorial using a sample report so that families kind of knew what they were getting into, like, oh, like what can this do? And do I want to see this kind of data? If it's distracting, just forget it. We didn't have any families turn down, use of the probe to read the radiology report. So after they saw, what it would entail, they agreed to have us upload their data. And then they interacted, with the experience unguided. And, in the clinic, this interaction with the report led to really kind of different interactions. So of course we were wondering, the patient, what we observed in observations was that, most patients were fairly disengaged. So now we're giving them a tablet. Are they going to be even more disengaged just looking at this tablet and kind of trying to figure out what's going on with their radiology report? What we actually found was that the discussions kind of started out as technical concepts, but that time that the patients and usually their parents were waiting, for the oncologist, they spent a lot of time kind of interacting with the information. They tagged stuff they wanted to ask about, and then the conversation with the physician was really rich. So their face-to-face interactions included visual explanations. The physicians were drawing on bed sheets and whiteboards to explain things, and it managed patient and family turn taking as well as doctor-patient turn taking. So kind of putting the teen in the driver's seat with this technology actually seemed right. We'd have to do much larger studies to verify this, but at least from this study, we saw the potential, right, for more engagement because the teen was sort of in the driver's seat with the technology, with the care team kind of around them. So that was kind of cool, and I think more could be done there. But our recent work focuses on the last theme a little bit more, which is enabling better understanding and communication about illness experiences and observations. So when we think about observations that we want to capture, let's take symptoms, for example. Most of these observations that we'll want to capture, right, that might be clinically relevant, they're going to happen outside of and between clinical visits. So we want to capture the patient's voice at home, at school, right? But these are kind of new care contexts for technology. Consumer technology that typically follows us on, and supports our daily activities. We're just starting to see mobile health technology kind of roll out. So there's a ton of work to do here and to think about what it really means to provide care between these kind of clinical encounters. So anyway, fortunately, researchers have created a framework for capturing what are called observations of daily living. So these summarize physical symptoms, to summarize kind of what this is, right? This is a framework, right? And so to summarize the major components of this framework, symptoms, mood, that kind of information, that would be status indicators, like status of how you're feeling. What you've done, your activities, those are behavioral indicators. And then social and environmental contexts that you move across as part of your day are considered exposures in this framework. So we knew the general types of observations that matter because we have this, but there was this question of how do we define and elicit the specific observations that matter from the teen's point of view. So we made design artifacts. We made graphical cards that depict observations. They depict activities, people, places. We wanted to use them to facilitate visual storytelling. And we call them visual observations of daily living. And so we based them on known measures in the medical literature, and then further expanded the list to include like lifestyle related things like listening to music, right? And so in co-design sessions, teens constructed narratives by providing a storyboard and kind of placing these cards, these graphical cards on their storyboard. And we created a library sort of together. So they could iterate on them, ask us to sketch new cards, right, or sketch them themselves. So we created this visual library depicting multiple aspects of the patient's illness experience. And then we really wanted to start in the clinic, right, because the mindset was there. But then we wanted to kind of use the representations we created to create further design instruments that could accompany these patients in their everyday life. So here's a close-up of some of the cards we used. We generated together with patients and the patient family. There's a storyboard of a patient in progress on the bottom left. Some advantages in using this approach were that we were able to scaffold the storytelling effort through these visual artifacts. And especially for patients going through chemo, recognition is preferred over recall of observation. So they could actually, again, through this scaffolding, it was a bit easier to put a narrative together. So we also knew from our prior research that teens can be in conflict with parental caregivers about how they assess what's going on and how they report on their own illness experiences. So, one key theme in this work is the need to be really mindful of power dynamics. So when you have adults or authority figures, even researchers, right, in the same room, thinking about how to neutralize power differences is really important. So in some cases, we had patients do some design activities together where we made sure there was only one researcher, but multiple patients. And we tried to be mindful of privacy too. So we tried to be fairly flexible, right, in this process. One big finding from the study is that using activities as anchors, it was easier for teens with cancer and blood disorders to express symptoms that were clinically relevant. And that was a big finding, because what we saw was that the ways in which teens were asked about their symptoms didn't match their mental models of how they wanted to explain their symptoms and their illness experiences. So they would see a pain scale, even one that was validated, right, and designed to be really patient friendly. It didn't resonate with them, right? And so we found that by using activities, when they told a story about the fact that it was difficult to climb the stairs, that led then to an easier ability to ask what was happening, what exactly was going on. Was there numbness? Was there pain? If you just ask, how's your pain? That's fine, right? And so these activities, through these visual observations of daily living, helped us identify how some of these illness experiences could be better expressed from the teen standpoint. Okay. So moving out of the clinic, we did another study using paper diaries to look at collaborative aspects of logging experiences. We included rheumatology and oncology and hematology patients and their parental caregivers, and we provided diaries for families to use to log their experiences, to do freeform sketching. We asked them to take photos or videos if they wanted to elaborate. This helped us understand in their daily lives what kinds of experiences they wanted to express. So now, through this CoDesign study, we're iteratively developing a mobile health application to better capture some of these experiences, and using the visual ODLs as a primary set of metaphors to help them construct what's going on in their daily lives. So this is just a very short. This is work that's definitely still in progress, but we have kind of working tablet application that enables collaborative family tracking of observations of the teen's illness experiences with flexible ways to elaborate through sketching or videos or photos that can be added to observations that the patient makes about what's going on in their daily lives. And then, one thing we found from the diary study was that teens often wanted to review diary data with their parents. Some diary data was off limits, some diary data they really wanted to share, and they'd rather just share that than talk about it, right? And so in some cases, they would share the diary data first and say, I don't want to talk about it right now, right? But then maybe revisit that later. So this also can provide ways of mediating what might be otherwise pretty difficult communication about, really scary symptoms and difficult illness experiences. All right. So the next two projects look more at clinicians than patients, and they examine how clinicians collaborate with AI-enabled systems. So we're moving from work conducted at Georgia Tech to work that I've been contributing to at Google. So this study was one I contributed to, but was led by Carrie Kai, who's doing a lot of work on human AI collaboration. And it kind of starts with an evaluation, but then kind of the learnings from that have fed back into model development. So, even the phases in the pipeline that I showed earlier, the idea, right, is that hopefully, if there's learnings that feed back right into previous stages. Anyway, so for this study, we were working with a machine learning model that our extended team at Google had created. And they built it into an AI assistant to directly assist pathologists with prostate cancer diagnosis and grading. Well, we already talked about, earlier, the fact that novel computing systems and, an AI assistant for pathologists is certainly one of them in this class, right? That often these systems have a hard time being integrated into practice. But we saw potential to better understand how pathologists could benefit from an AI assistant. So Carrie and our team noted that there was a lot of work happening on the explainable machine learning side, the model interpretability side of things. But we noticed that in human-human collaboration, people get to know each other to learn how to work together. And there's this kind of getting to know you phase, right, that heavily influences then later approaches to collaboration. So how could we help human pathologists get to know an AI assistant? Well, we looked specifically at the onboarding phase. Like if we think about this as technology onboarding, how should we design that onboarding process to enable these physicians to understand what the AI system does, to make a decision about when to use it, if they want to use it and how. So we first focused on identifying information needs. And to do this, we conducted a study with 21 pathologists. Each pathologist participated in an interview. They told us what information they wanted to know about the AI assistant before they interacted with it. Then they actually got to interact with this thing. They performed cancer grading on digital pathology images for prostate cancer. And they used a think aloud protocol in their grading process as they were examining the results of the AI system on the tissue sample. And then after performing this assisted grading for the third phase, they continued to talk to us through semi-structured interviews to reflect on the experience and tell us additional information that they thought would be useful. So we found 4 classes of information that pathologists really wanted to get to know the AI. And first was capabilities and limitations. What is its overall performance, but also what are its particular strengths and limitations under specific conditions? So there are well-known edge cases or certain types that are particularly difficult to grade because of characteristics of the tissue sample. And so especially when the pathologist disagrees with the AI assistant, having a better understanding of its strengths and weaknesses both globally and on these subcases was really, really important kind of information need that they had. I'm going to be mindful of time, so I'll move a little quickly through the rest here, but functionality was really important. And in this context, that means what information the AI assistant has access to and how it uses it to make a prediction. So we heard questions like, do they have the patient's chart? Do they have prior data? They have prior samples from this patient? And so, this was really important to and what does it know in terms of biology concepts, right? What medical ground truth is it using? The medical point of view was also really important. So the system, even though it's trained, it does have a subjective, globally a subjective point of view. So meaning, does it tend to be more liberal when grading or more conservative when grading the severity of cancer? And finally, the design objective. So what the assistant has been optimized for, is the rate of false positives versus false negatives, more important? Is it tuned to compensate for common human errors, right? As opposed to being independently as accurate as possible. So, this design objective was really important. And so now we're building on this work to use onboarding actually as an exercise, like a participatory exercise, so that early in model development, we can start an onboarding process, see what people want to know, see if we can actually tell them what they want to know. And for those things that we can't, what would we need to do to tweak how we're designing the model and building the model, and then kind of how we're incorporating that into a larger computing system to get feedback on kind of further AI assistant development. So there's more. I'm going to kind of move quickly. There's more here in our CSCW 2019 paper that Carrie led. And one more, I'll just kind of do a quick overview. This study was another that I contributed to, led by Emma Beatty at Google Health, who did a lot of the on-the-ground field work. So, this gets at the later phases of the AI pipeline, not into longitudinal use. We're not quite there yet, but it focuses on AI-enabled screening for diabetes patients. We know that diabetes is, a growing problem around the world, and it brings complications. So diabetic retinopathy is something we have to screen for with diabetes patients to catch it as early as possible if it might be developing. So this is a condition, diabetic retinopathy is a condition caused by chronically high blood sugar damaging over time the blood vessels in the retina. So the blood vessels can leak or hemorrhage, and this causes vision distortion or blindness, right? So for a small percentage of people, there can actually be blindness, but this is one of the leading causes of vision impairment in the world. And so our team at Google developed a machine learning based model to detect diabetic retinopathy and macular edema on standard fundus photographs. So these are photographs of the inner lining of the eye, and that includes the retina, so that we can look at the retina to determine whether there's blood vessel damage. So it makes an assessment of whether or not the patient needs to be referred to a specialist for treatment. And it also has to perform some grading, of damage of the blood vessels in order to do that. So in retrospective evaluations, the system performs really well, essentially on par with a retinal specialist. So the Thailand Ministry of Health was interested in partnering with us because, roughly 1/3 of diabetic patients in Thailand have low vision or blindness in one eye, and there's a shortage of specialists. So it can take a really long time for a patient to get eye screening results, and we need to get results to them much sooner. So we deployed our AI-enabled screener in 8 clinics across Thailand in a 1.5-year-long prospective study. These prospective studies typically collect additional evidence of model accuracy, in the actual care context. And we did this with, roughly 7,600 patients. Now, again, we know that for a system to be successful in the real world, and that needs to not only be accurate, right, when we test it before deployment, but we need to meet real people's needs and understand kind of how it fits into these actual real world workflows. So in this case, we wanted to make sure this was going to work for the nurses who would be using it every day to conduct these screenings and the patients that it would serve. So alongside the prospective study evaluating system accuracy, we conducted a human-centered study that included field research at 11 clinics across Thailand. And this was really Emma on the ground in Thailand over a period of 8 months doing interviews and observations before and after deployment of this deep learning system. And so then we collected interview data, observation logs. We looked at log analyses and usage data of the system. And so, and compared this, these data to understand how well did the system work in practice. Well, one of the first things we learned had to do with gradability. So gradability refers to that ability to read the image to make an assessment about how, if the patient was at risk of diabetic retinopathy and would need to be referred. So when clinicians are conducting screenings, they have these guidelines, of course, that they apply to determine if the photograph of the retina is clear enough to make the assessment about whether or not the patient has diabetic retinopathy. So these guidelines and how the images are interpreted, that can vary between clinicians. So just like clinicians, though, the deep learning model had to set a threshold for features around image quality, like blur and darkness, before it would make an assessment. If the image is extremely blurry, just like a clinician, the model might say, I just can't make a determination, right? It's ungradable. Well, we learned that after deployment of the deep learning system, when we looked at system logs, on average, about 20% of the images couldn't be read by the model. And during our field work, we observed several causes for why this might be happening. So there was a high volume of patients seen at the clinic, right? And there was limited time to align the patient to the camera to take a good image. Again, this has to do with the busy clinical environment, which is very different from the development environment, right? And the lab setting in which this thing is tested. We're also in perfect lighting conditions. So to take a good image, a patient's pupils need to be large. And screenings were taking place in brightly lit rooms because nurses were sharing space where there were teeth exams or other patient consultations. So there was no time to let pupils adjust for each photo. So in addition, there were older cameras. This was a lower resource setting. And so we really had to familiarize ourselves a lot more with these environmental conditions to understand kind of what would affect system performance in that setting. All right, so as a result, we were able to make some tactical improvements, right? Like we can repair the cameras, we can help repair cameras that have to be fixed, right? Or add a curtain or drape to help the pupils adjust. But we also made changes to the research protocol. Patients with ungradable images were highly inconvenienced. So, we increased ophthalmologist involvement in our research protocol, finding that using a combination of AI and a human clinician was actually best. And the model is in active development so that we can continue to improve upon gradability and other performance metrics and better plan for environments that might not be ideal, right? And so since this research, we've also held participatory design workshops with people from future deployment sites, like nurses, camera operators, retinal specialists, a doctor who would receive referred patients from the system, so that we can better understand kind of how to design, a new workflow, how a sociotechnical system can be designed, right? So that we're involving people in that process and proactively identifying potential barriers to implementation, potential barriers to usefulness for people. So there's more, again, I'll wrap up because I think I'm at time here, but there's more in a Kai paper that we published earlier this year on this field work. And I think it's probably time for questions. That was fast. That seemed to go by really fast. I hope you had the same experience.
Thank you, Lauren. I felt like it was a poem that I was listening to. Thank you so much. Questions from the audience. Maybe I'll start with some. The big thing that I wanted to ask was, I have many, but the one obvious one that popped up, this conversation around explainable AI and the methods that get developed for explainable AI. I mean, there is this other thing that's emerging, right? That all these problems of, lack of trust and lack of, communication and all these things will be solved by explainable AI methods. So what's your take on that argument?
Well, yeah, that's a big one. So, certainly explainability, I think, if it can't be explained, it's on the one hand, right, thinking about what we learned from the onboarding study, we don't want to forget that global properties are just as important as details of how a model works. So I think there's a lot that we could, from a research perspective, explore around what are the global properties people need to know, right? Like, I don't need to know what specific neurons are firing, right, in your head as you ask that question, but it might be helpful to know, your research background and your point of view, right? And so I think that there's that part of explainability and mental models, what mental models people bring to these interactions is really important, because there's also, explainable for whom, right? And we also know that these systems are boundary objects. So, multiple people potentially in a work context in multiple roles will have to use this information. And so I think that's another, as we think more broadly about who is the user, and remember that these systems are often situated in complicated social contexts, where what's explainable for one person in one context will be very different when you have a group setting. So I think I do think it's a really rich space, but I think that there's so many other areas of trust that we also have to understand. And some of those areas, for example, trust is, I'm so glad you mentioned it, because there's so many variables and there's histories that we have to consider. Like, we're thinking a lot about community-based participatory research lately and how we could how we can engage communities more effectively, or even at all, in some of our research. And it's like, we have to acknowledge that in some cases, knowledge of communities, you know, and I'm talking from a historical context, right? Not calling out any individual researcher or company, but from a historical context, some knowledge imparted, you know, by communities has been abused, or retold, right? And so there's, so of course there's mistrust, right? And so I think, especially in health contexts, right, there's also a lot of historical background that we need to understand around who the system has worked for to date and who it hasn't worked for, and why there might be mistrust in the medical system as a whole. That's really important context for understanding trust in systems that would work within that medical context. In some cases, we've seen that, you know, when the AI agrees with a nurse who might be lower on the clinical hierarchy, the nurse feels more empowered because, look, you know, what they had to say was validated. So it's really interesting that, I think there's just so much nuance here, but so in some cases, you know, we've seen examples of AI legitimizing what should have already been sort of legitimized knowledge. And then in other cases, we have systems that learn, if we're not accounting for bias, right, they can actually do damage to knowledge and abuse potentially knowledge that a community holds. So I don't know if I've answered your question, but I got to ramble on about things.
I was just looking for your perspective. I know the answer is not going to be a clean-cut answer, but it's I just wanted to know where you stood with respect to that. I mean, does anyone else have a question? I thought I saw some faces pop in.
I think this is a very fascinating topic. It's very, very interesting, Lauren. I'm curious about if you have any thoughts on the intersection of this and healthcare insurance, and kind of the implications of this sort of AI-driven understanding, and whether that can, well, what can emerge from that? What are the positive or negative or both implications?
Yeah, there's some really good writing on the role of the commons in insurance, that argues, and I'll try to share it with this group. Let me find the article that's coming to mind, and I'll share it. But it talks about some of the harms that can come from over personalization of things like risk. So I think this is a really important topic. Yeah, I mean, so I think a commons model, for many reasons, tends to work well in societies like ours. Yeah, so I'll kind of stop there. Yeah.
Yeah, I understand. I wasn't, sorry, it was a tough question to throw, but I am legitimately curious on like the implications of this, and how it could be used and misused. And people would feel betrayed by the AI, I think, in some communities as well. But you know, I understand.
I think it's a really important research. I think that's a really important line of research. Yeah.
There is a question in the chat by Michael Seifert. Michael, do you want to ask, or do you want me to ask?
Oh, I was just saying, you know, that I think this is great, and I want to do some more research, but I have to go.
Thanks for attending. Sorry we were a little late.
Yeah, it was good. Thank you. Bye, guys.
Kim, do you have a question?
Bye, everyone.
Yeah. Thanks, Michael.
No, just thank you. This is really fascinating work, and also really personal to me. I was 13 when I was diagnosed with lupus, and so this was 20 years ago. So there was no iPhone apps at the time, but thinking about these kind of interventions that would have made a huge difference to us at that time is really powerful. So thank you very much.
Thanks for that comment.
Byron, do you seem to have a question?
No, I was just also just wanting to say thank you for the great talk. It's a very fascinating subject, especially when we're thinking about the artificial intelligence as a colleague. In a sense, I've thought more about human robot interaction, and I think many of the same questions and problems arise. And I think there's something to learn from looking at solutions that come from this field in that field as well. So,
Agree.
So thank you, everybody. I mean, Lauren, I'll reach out to you for some more questions, but we'll let everyone else go.
Yeah, I know this is kind of late, so thanks everyone for hanging around. And yeah, would love to discuss more anytime.
Yeah, thank you.
Fantastic, Lauren. Thank you. By the way, everybody, next week we do not have a speaker yet, but if you would like to speak, maybe reach out to Kayla or myself, and we'll put you on the schedule. So first come, first serve. If anybody has a burning topic they want to discuss, next week's open for that. All right, see y'all next time.
Thank you.
Yeah, thank you, Pavan. Have a good day.